include in my lecture notes.
Okay?
Oh, my purple highlighter, just in case you're wondering.
And I do have yours also.
Oh, I wasn't aware.
I just have to let you know.
Perfect. I'll just sit back here,
Okay.
unless you want me to stay up here.
First of all, let me thank everybody for letting me come and be a part of your classroom. I have enjoyed education, which is why I'm moving on from my master's. I'll tell you a little bit about myself. I know you guys, some of you know that I'm the director of the emergency department. I started my nursing career back in 1991. So I've done many different things and seen many different things, but I started in a nursing home, which, you know, was a love at the time, and moved on, did med-surg. I did oncology for a while. I was in ICU for about 6 years, and I've been in the ER for 11 now. Every one of them has a great area. As a med-surg nurse, like Alicia says, they don't get credit for what they do, because you guys going onto that floor will see everything. Patients who think they're stable go to that floor, and then they become unstable, and you have to always be thinking and critically aware of what your patients are going through. So they do not always get the great credit that they deserve. So just know going into that, it's I said nursing is a great career. I love it. The old saying goes, if you like your job, it's never work. So that's how I am. I love to go to work every day. So I'm going to talk about cholelithiasis and cholecystitis. I put the little case study together for you guys, so we will go over that after we're done. And this is just a couple of my little notes on here, but I'll write on the board so that Alicia is able to take pictures of it and put it on your notes. So cholelithiasis. Does anybody know what that is without looking off of the board? Okay, so cholelithiasis, number one, is the most common disorder of the biliary system. So it affects approximately, depending upon which resource you look at, it's going to tell you anywhere from 40 to 60%. Some places will say 90%. Just know that it is one of the most common biliary disease. You don't have to go quite, into the percentage. We're not going to worry as much on that, but it is in your book at different areas. Women are affected more than men, so lucky you, Spencer. You're the only man in this class now. And has anybody heard of the 5 F's? Okay, so the 5 F's stand for female, fertile, fat, flatulent, and let's see, where's my last one? And 40. So one of the common denominators for cholelithiasis or gallbladder disease is women over the age of 40, if they're obese, if they're fertile, because some women are still fertile at the age of 40, and gassy foods. People eat the wrong diet, produces a lot of gas, all that stuff can affect the gallbladder and irritate it more. So that is one of the things that you will read in your book, common denominator of cholelithiasis. So inflammation of the gallbladder, I guess I'll finish writing that down. Gallstones, the cause of them are unknown. And there is a really good picture in your book with a gallbladder full of gallstones, and that is very, very impressive. So they truly do look like that. I've never seen one that full, but on Sono, but that is a very, very full picture. Most gallstones tend to be related to cholesterol. That's the number one type of stone. And so think about what our cholesterol is in our body and where it comes from. We always get checked for cholesterol once we get to that age of needing cholesterol meds. So you're looking at your lipids and your cholesterol and your triglycerides and all that stuff basically comes from our diet. Genetics, yes, you can have a really bad history of family genetics that causes high triglycerides also, that can be passed down. So when you have high cholesterol and your body doesn't produce the bile correctly to break it down, that bile, cholesterol can saturate the bile, which then causes these stones. There are also bile salts. And calcium stones can also be in there. So when it's a supersaturated stone with cholesterol, it's called lithogenic. And that's just one of those, like I said, supersaturated stones, supersaturated with cholesterol. Is there anyone that you can think of that might be at higher risk? Just thinking about what type of a person would produce extra cholesterol?
Someone who eats McDonald's all day.
Yeah. Very, very true. Yes, people that eat McDonald's a lot. So when the gallbladder doesn't function very well, it also becomes sludge. It gets sludge in there. So if you think about a true drainage pipe, because that's kind of what the gallbladder is. It produces the bile. It's supposed to come through the common bile duct, drop it into the duodenum, so it works as a flow. It helps break down food, these enzymes that are produced as it's going through our intestinal system. So if you have that sludgy gallbladder that's not producing bile, it's kind of like a drain pipe. You have to have Roto-Rooter or their Drano, same thing with the gallbladder. It gets full of sludge and it doesn't work as well. So people who are obese, they're not very active, so their sedentary lifestyle can cause an increase in gallbladder disease. And pregnant people, why do you think pregnant women have gallbladder disease?
Gain a lot of weight.
They do gain weight. Usually that weight goes away in 9 months, but they do gain weight. Pardon me, did someone else say something? Okay. One of the reasons, and gallbladder disease, the gallbladder flare-ups, is very common in pregnancy. And what they will try to do is they will try to milk that gallbladder through the pregnancy so they don't have to go to surgery. But it does happen, it's very common, along with appendicitis, which I know that's not on our set right now, but those two things do happen a lot in pregnancy. When you're pregnant, you produce extra estrogen and progesterone, and those things help produce cholesterol, which then helps form this gallstones or even sludge. And so that's one of the reasons pregnant women have gallbladder disease. And again, if they can get the lady through the pregnancy, that usually will calm down in a couple months afterwards, so they may not have to have a cholecystectomy, but that is a very real possibility for them. Stones can remain in the gallbladder for years and years and nobody even knows about them. It's one of the most common undiagnosed gallbladder issues, because they'll have stones and not know it until one day they just have a flare-up, and that's usually what happens with them. They can migrate, so like any other stone, a kidney stone can migrate, a gallstone can migrate, they can come down that cystic bile duct, and they can either go through, which would be great if it's small enough to get into the duodenum and just pass out through our stool, or it can get stuck. So if it gets stuck, what happens? What happens if something's stuck? You can't move through. Everything backs up, right. So then your gallbladder swells, it gets inflamed, you start having pain, and that bile can't get through. So remember on your case study when I asked about that sign when you're in your belly and you're digging in? Well, if your practitioner, your physician, or your patient's laying down and you take your fingers and you hook them up underneath that rib and you have take a big breath, that gallbladder's inflamed, remember now, so it's sore. And when you do that, it expands everything down the liver and the lungs, and then your fingers kind of touch the outside of your skin, touches that gallbladder, which is why they do a really quick intake of breath because it hurts them. So it's that inflammation of that organ. That Murphy sign is what, and a few of you did get Murphy sign, and I don't know if you got it after you flipped the page over and it was in there or not. When you get your case face back, we'll go over it. But anyway, so that is why, is that inflammation of that gallbladder swells, and that's painful when anything touches it. You guys know what the difference of, do you know what it's called when you have referred pain? Like say, the pain in the gallbladder gets referred to the shoulder. Do you know what that's called? Rebound. It is rebound, but it's got another one of those lovely names that you'll hear a lot. When you're reading, if you go to read any type of physician's documentation, anything like that, did you?
No, just.
It's called Kerr sign. Has anyone heard of that? K-E-H-R? K-E-H-R. Kerr sign. So Kerr sign is radiation again. The pain moves so that gallbladder's down here, and you know that you're going to have some pain in here. But when it swells and it starts rubbing on other organs or anything's going on with it, that pain can refer up into that right scapula and right shoulder. That's called Kerr's sign. So if you're reading some dictation and the physician writes positive Kerr's sign, that would be why. It's that radiation, that pain. You can also have the same thing on the other side with your spleen, and it goes up to the left side. But so Kerr's sign, radiation. Yes?
There's a good picture in the course and the helpful resources that shows all the referred pain sites in your body that you guys can look at.
Okay.
Helpful resources.
People can also have cholelithiasis and never have stones, and those are called acalculous cholecystitis. I'm going to take up the whole board, you guys, because I read a lot. So, acalculous cholecystitis. Those are generally when there's not stones blocking the ducts when they do their tests. Okay, so let's look at if we have cholelithiasis and we know we can, one, let it ride. If it's not that bad, a person comes in, they get some pain medicine, they get it calmed down, we might not have to do surgery. What type of interventions and what type of education are you going to give your patient with cholelithiasis?
Increase your fat intake.
Very good. Decrease your fat intake. Probably the number one education that you're going to give somebody with gallbladder disease is decrease your fat intake. Because our body works as a well-maintained machine. Food goes in, all these enzymes are produced from our liver, our gallbladder, and our pancreas. They go into intestines, that heat break down the food, moves through the body, comes out. Well, when there's a disruption in any one of those processes, then we have disease processes that happen in the body. So too much fat, if your gallbladder is only functioning, say, at 50%, it can't produce the correct amount of bile to break that down. So decreasing the fat is a very good thing. Inflammation, I know we talked a little bit with like the NSAIDs and things. Again, NSAIDs, unlimited amount should typically be okay on a person, but if you're taking handfuls at a time, then you have to worry about ulcers, gastritis, things like that. So you can take anti-inflammatories to help try and calm down that gallbladder. And some just NPO and doing clear liquids for a few days also can help calm down that gallbladder. So what kind of manifestations? So pain. What kind of pain do you think they're going to have? I'm sorry, what?
Kind of like kidney stone.
Yeah, some colicky. Okay, so let's talk about biliary colic. We can write that up here. It's kind of a deceiving name because if you think about colic, you think about a spasming type of a pain. That's colicky. Anybody have children in this room? Was your baby ever colicky? They cry a lot. They're, very unhappy little people.
24 hours a day.
Yeah. So colicky is a very like a spastic type of a pain is what you refer colicky to. But biliary colic, like I said, it truly is more of a steady pain. It's a steady, can be very sharp, can just be very annoying. You just feel like there's somebody just in there with their fist digging in. So the colicky part is a little misbehaving of the term, but it's the fact that that organ is not acting right. So that organ is mad at you, it's inflamed, it's irritated, so it's colicky. So that's where they come with that term. So it can last short amount of times or long amount of times. So 3 to 6 hours would be a typical flare-up for a gallbladder before people finally are like, I'm done, I can't take this anymore, I have to go get some help and get some pain medicine. So when they come to you, one of your first things you want to do, what do you want to do to help them? Control their pain, yes. What kind of pain medicine would you think Tylenol ibuprofen is going to do it, or do you think they're going to need something stronger? Something stronger, okay. And IV or PO?
IV.
Very good, okay. So if someone's having a gallbladder attack, Do you want them to eat or do you want them to not eat?
Not
eat.
Not eat, very good. So we want to keep them NPO. We want to treat their pain. And if they're NPO and they can't eat or drink, what do we need to probably give them also? Yeah, little fluids to kind of keep them hydrated so they don't become dehydrated. On one of those worst case scenarios where people are really, really ill, they may also end up with an NG tube to help decompress the stomach. So that is also something that you can think about. Has anybody ever had pain so severe it makes you want to pass out?
Yes.
What did you look like or feel like? Was you just
Fetal
all nice
precision.
and
Fetal.
Like pale.
pale,
Sweaty.
sweaty?
Sweating.
Yep. Wanting to vomit, right? You feel miserable, and that's what people like this, when these gallbladder attacks hit, they come in and they just don't look good. They are very pale, sweat's pouring off of them because they hurt so bad. Their blood pressure could be through the roof because they're in so much pain, tachycardic, and they just generally don't feel good. Do you want me to write signs and symptoms now, or did you guys get that? Okay. So then we draw lab, as we talked about the case study. What kind of labs do you want? What do you want to know about your patient when they come in like this?
Cholesterol levels.
Yeah. You could check cholesterol levels, white blood cell count, because we want to look for what?
Infection.
Inflammation and infection. And all of those liver enzymes that go along with the liver, the pancreas, the gallbladder, we want to look for those to look for elevation. Very good. And if your gallbladder is backed up and the fluids aren't going down where they're supposed to, they're going to back up. Do you know where they're going to back up into? So we'll do our little patho. So if this is the gallbladder, the liver just kind of hugs it and it sits right on top of it. So things can back up into that liver, which is why we get things like bilirubin, and then we can start getting jaundice and things like that. So stuff backs up in there. So that's one of the reasons why we want to check all those liver enzymes and look for, bilirubin also. Right upper quadrant tenderness, and they may be rigid depending upon how sick they are. If their stomach, if they do have an infection already and they're leaking bile, they could have a peritonitis, so their stomach might be very rigid and very, very painful. I talked about the diagnosis. Okay, so urine. What do you think we want to look for in urine? Color, very good. So if you have someone who's producing extra enzymes and it's coming through their kidneys and out their urine, what color do you think it's going to be?
Bloody.
Dark.
Dark, yes. May not be bloody, but it will be typically dark. So you actually, when someone produces enough bilirubin in their urine, you actually can take that urine and you can shake it. Not that anybody typically does this, but you can shake it and it becomes bubbly and frothy. That's the cholesterol and stuff that's passing out through your urine. But it'll be dark. So it can be light tea color, it can be dark, it can be brown, it can look kind of red tinged. So all of those colors and what they're looking for. And when they do your urine analysis, they'll show you how much urine bilirubin is in bilirubin that's in your urine, and that helps to make those diagnoses also. Okay, treatment. So we've gone from cholelithiasis, and what happens to the next if the gallbladder doesn't calm down and we now have that inflammation and that infection of gallbladder? What's it called? Very good. Cholecystitis. So that is the actual infection or inflammation of the gallbladder. No, I lied to you. Yes, infection. Yes, that's correct. I put that on the wrong thing over there. Cholelithiasis is just gallstones. Number one treatment, surgery. What's the surgery called? Cholecystectomy. Very good. How do they do that typically? Do you guys know? Laparoscopic. Very good. So when they do a laparoscopic, they put the 4 little puncture wounds in the abdominal cavity. Have you guys done a surgery over rotation?
I just did my test.
Did you? Okay. Did you get to see anything like that?
I just.
Yes. So,
Bladders.
okay. Did they inject the belly with the air? Is it not amazing how big that stomach can get? So, yeah, people can look like that ascites on that video. That's how much air they get inject in there, because the surgeons, of course, need to be able to see around all those organs with their utensils that they're using in their equipment. So they'll blow that belly up so that they can see. They can go in there and snip and suck that gallbladder out. If that gallbladder is so big and large and swollen that they can't get it out their scope, they will have to convert them to an open and they will have to take it out the old-fashioned way. Most people with a cholecystectomy that's done with a lap chole can go home either later that day or that next morning, depending upon how well they do with anesthesia and if they're tolerating that kind of stuff. So you'll have pain after surgery just from having your stomach blown up. That air that they put in there, that CO2 that's in there, is very irritating because the inside of your belly, your abdominal cavity, is not like anything in it. It doesn't like blood, doesn't like air, so whenever that's in there, your body says, get this out, because that's not supposed to be there. So I want to tell you, and I'm very grateful, you guys, this is where I like to teach. I learned something from your case studies, because many of you put what position to put them in, and everybody wrote to put them in the Sims position. So I'm scratching my head going, I don't even remember what the Sims position is. So what do? Go to Google, right? Google Sims position. I start looking on UpToDate and things like that, and that is one of the treatments to remove that air is to put them in that Sims position. So everybody who put that down, kudos to you guys, because one, you taught me something that I had forgotten a long time ago, and it works, because I would have never thought to put someone in that had just had surgery over on their side. It's not something that I typically would have thought of at the time. So I wanted to let you guys know. Good job on that. Okay, so cholecystectomy, pain meds, IV fluids, NSAIDs if they can have it. Say they are not a candidate for surgery at this point, but we know we need to go in and we have to help them. The physician has to figure out if there's a stone stuck or something. What are some other procedures that can be done to help them?
X-ray. Or an MRI.
Yes, to all of those. So x-ray typically is not really done with a gallbladder because they don't see much. With that being said, if you have a gallbladder that looks like your picture, and some of those are echogenic that might show up, you may see something that looks odd. But we typically don't do that. What's the number one radiological exam to diagnose gallbladders? Ultrasound. So ultrasound is done first and foremost. One, it's non-invasive. Two, it's very quick and easy. And three, it gives them a really good diagnosis very quickly of what it looks like. I have a picture of gallbladder. So on this screen, so this very first picture on the top, if you look at it, is actually, that's what you would see if you were looking with the sono head, is you see one gallstone. And the acoustic shadow is just basically like us. We have a shadow, the sun's hitting us, our shadow's on the ground. That's really what it is. So that stone is blocking by the angle of the sono head, so you get a shadow that goes down. And then this next one that they may see is the one that's full of sludge. And it doesn't have that specific shadow because sludge is more, it's spread out. So it's all through the gallbladder area. But those are two kind of really good pictures of gallbladder disease with the sono. The ERCP. We don't do that in Hayes either. That is one of those because it requires a special scope. So as we were talking about the scope with the EGD, they do it the same way. They go down and they look, however, with their scope, they're able to come back up to the duodenum and they can go into that cystic duct, because that way if there is a stone that's stuck in there, they have a little basket that comes out of their scope and they can grab it. If it's stuck so bad that they can't grab it without doing damage, then they can set the patient up for lithotripsy. So we can do lithotripsy on kidney stones, we can do them on gallbladder stones. Kidney stones break up a little easier than the gallstones do, but it is something that also can be done. So let's write a couple treatments on here. So we got the ultrasound, we got the ERCP. You can do an MRI to look at the gallbladder. If you don't, you can do a CAT scan, and you also can do an MRI if you're not finding what you need for diagnoses. So CAT scan can be done, MRI. CAT scan also is quicker. They may or may not use dye in it. It just depends on what they're looking for. And they're able to, like I said, be in and out of those really quick. MRIs typically take a little bit longer to do, so they would reserve that for the last. And then lithotripsy. So in your reading, did anybody read about oral medicine that they can take? There's actually a solution that they can take that will help break down the gallstones to help dissolve them. It is not a fast process. It takes weeks to months to break down. So they can use that in conjunction with lithotripsy until the stones start breaking down and dissolving and getting passed out. So what kind of nursing goals? If you were talking about those care plans and those care maps, what kind of nursing diagnoses or nursing goals are you going to look for on a person that has gallbladder disease? Pain, okay. So you would definitely focus on pain. What else?
Make sure they know they're fit.
Okay, so yes, so we've got a pain, we've got a diet, so, and someone said infection, right? So we've got infection, so we already have 3 nursing diagnoses right there. Who can come up with some more? Because there is more. How about elimination? What color, and I believe on your guys' test, there was something about
Drink fluids.
drink fluids. There was something about your stools on the last test, I think I read it. Anybody know what it is?
Full fat.
Okay, what's it called?
Diarrhea.
Okay, start. So, fatty stools, basically they float. They don't sink. So, people need to know that that's normal after they've had their gallbladder out or having gallbladder issues. The other thing is, what color can they be?
White.
Yep, white, gray, clay colored. So when the bile does not, again, go through to the duodenum to get mixed up into the intestine to come out in our stool, it's missing that. That's what gives our stool color. Because what color is bile? Does anybody know?
Green.
Yep, a green to a yellow is what bile typically is. The paracentesis that we've seen, it typically is that color, or it can be very green. And so that kind of mixes with our food and everything else going on and gives us that color. So when that bile's not there, we have clay-colored stools, so they can be white or gray. All right, so we got nursing diagnoses. I'm going to look at the rest of my stuff. Medications. There are medications that can cause gallbladder disease. Does anybody know what ceftriaxone is? Anybody looking at your medication list, see that on a med list? I want you to look at that next time you go to your clinicals. Okay, so let me tell you the other name. How about Rocephin?
Yeah.
Okay. Believe it or not, again, I learned something new. This is why I like to teach and I like to be educated, because I always learn. Ceftriaxone, and I got this off of UpToDate, one of my resources that I use, is a major cause of biliary sludge formation in hospitalized patients. How many of your patients that you know have been on Rocephin? A lot. So the reason being is biliary excretion accounts for up to 40% of Rocephin's elimination. So that's quite a lot that has to go through that area to be excreted in the body. So if you have an already malfunctioning gallbladder or one that's a little finicky, and you start treating people with Rocephin, you actually can then send them into a gallbladder flare, which, like I said, I learned a lot on here, so I wanted to share, because I thought that was, I did not realize it, and truly we use Rocephin for everything, broad spectrum, everybody gets it. So I thought that was pretty interesting. Let's see if there's anything else there. And then we talked about pregnancy. So prevalence, Caucasians are least affected in African Americans with gallbladder disease. Most affected are Native Americans, Hispanics, and like Scandinavian heritage, so Indians and things like that. I couldn't find why, per se, but I wonder if it has to do with their diet,
The way we
because
cook.
everybody eats differently. So, so yeah, that's that. So African Americans have the lowest prevalence.
A lot of oil. A lot of foods.
I'm trying to see, I just want to make sure I told you guys everything that will help you. Biliary colic, we talked about that.
I have a question.
Yes, please ask
In
me.
the book, it says that that first word is gallstones.
Yes, I was going to change that.
Second one was inflammation of the gallbladder.
Yeah, and inflammation and infection can be interchanged at times, so I'm one of those old people that still said, but this, yes, I meant to change this to gallstones and I never came back and did that, so thank you for telling me, so you guys can all make sure you correct it. Cholelithiasis is gallstones, cholecystitis is an infection or inflammation. The infection being when things are blocked and it stuff backs up, the bacteria sets in, it has nowhere to go, so then it gets infected, which is why we want to know that white blood cell count is elevated. So thank you for, again, I wanted to change that, and I hadn't done that yet.
I
Control
was
pain.
just a little confused because I was looking at the book and I was like, wait.
Yes, you are correct. Okay. All right, so what I want to do really quick now, I'm going to pull up the case study so we can kind of go over it, and you can, now that we've heard a little bit about cholelithiasis and cystitis, does anybody have any other questions first on that part? Okay. Okay, so here is our case study. So you have a 26-year-old white male who presents to your clinic. He is complaining of abdominal pain, and it's been going on for about 5 hours. Nothing's really helping his pain. So what's our first concern is he appears to be obese, right? Obesity, granted he's a male, not a female, but obesity causes gallbladder disease. He does have a temperature, so we're automatically thinking what? He's got an infection or an inflammation or something going on. A little bit tachycardic, respiratory rate's okay, and blood pressure's elevated. Oh, does anybody want theirs to look at real quick? Is it okay if I just give it to you and you guys pass them through and take your own? Okay. I think that was, and then here's the last two that came in today. So Alexis and Amy. Okay. Yeah, is that right? Yeah, thank you. Okay, so blood pressure, what do you think? Is it high, normal? What do we talk about pain? What happens to our body when we're in pain? Blood pressure goes up, right? So do we want to treat this? I mean, are we concerned about it? Big thing with the blood pressure like this, it is elevated, yes. But when you look at the numbers and you look at the patient, and if they're having a lot of pain, we're not necessarily going to do something like give him a blood pressure medicine to bring it down. We want to treat his symptoms first and see if that comes down naturally on its own. Okay? So how will we treat him? Pain medicine. Very good. So there's something else I learned. Again, I'm a learner. A couple of you put on, and I have to take my notes because I wrote it down over here, put on old carts. So I had to look that up too. Old CARTS stands for onset, location, duration, character, aggravating or relieving factors, radiation, timing, severity. So that all I'm assuming just is right to pain. That's the questions you want to know about pain, right? So again, old nurse. When we talk about doing a history on people, and you will learn many analogies to remember stuff by. I use sample as my history taking word because it hits everything. It doesn't just hit pain. Old CARTS talks about the pain, which you definitely can use. But if you look at sample, it breaks everything down. So you have your signs and symptoms. So you're going to ask, your patient, what are your symptoms? What's your chief complaint? Obviously, abdominal pain. He's had it for 5 hours. Nothing's helping his pain. A is for allergies. Look through your paperwork. I did not see people asking about allergies. That is a very, very important question to ask everybody that you take care of, as you know, with bedside assessments and everything, and their allergy bans, because you need to know if, one, they know if they have any allergies, or two, if you're going to give any medicines that they're allergic to. So A stands for allergies. And then what kind of medications do you take? So is he on gallbladder medicine, or try, any type of cholesterol lowering medicines or anything like that that could cause issues? Is he on NSAIDs? So always ask about those medicines, and don't forget your over-the-counter meds, because there are a lot of like herbal things that can cause people to have thinned blood. So if they're taking some of those and then we start giving them, Toradol IV or something, so we can potentiate effects of bleeding. So you want to know those over-the-counter meds also. And then past medical history for P. What type of problems do you have? What kind of surgeries have you had? Family history, anything like that. When did you eat last? So your last oral intake, and then the events leading up to this onset of symptoms. So again, through your nursing school and career, you are going to learn different analogies, but this is just one that I use, so I wanted to share. You guys can use it or not, it's up to you. But anyway, it does help you break down things so that you don't forget stuff that's important when you're talking about your patient. So look at that. Who said McDonald's earlier? That's what he had for lunch. Not only did he have a Big Mac, but he had a quarter pounder with cheese and fries also. That's a lot of food. No health problems routinely. He doesn't see a physician generally. Broke his arm in high school playing football and had surgery of that. No other surgeries. He is allergic to sulfa, which we now know. Takes occasional Tylenol and ibuprofen. Pain started about 2 hours after eating lunch, progressively worsened since. He did take Tums, which didn't help. When we're talking about all those medicines, peptic ulcer disease and everything that you can take, when you have somebody who says, oh, I chew Tums, and I chew Tums, and I drink a lot of Maalox, always think they've got definitely something with GI going on. And they do eat a lot of Tums, but it also could be cardiac, which I think you guys are going to learn later, right? So, Tums, he eats his Tums. Nursing priority, we talked about a lot, so I'm not going to go over that again. You guys did a good job answering your priorities, like getting your labs and your tests and all that stuff. You did a very good job with that. So promote rest, relieve pain, maintain your fluid and electrolyte balance, are a couple things, prevent any type of complications, and provide information about the disease process and prognosis. And we already talked about the treatment. He's obese, so being in the hospital, he's definitely going to get put on some type of a low-calorie diet, right? So he might not like us because he's not going to get a Big Mac and a quarter pounder with cheese in the hospital. But good education on why it's important to limit that type of food. Relieve his pain. We talked about the tests already, so we won't go over that again. Lab. So as we look at his lab a little bit, and a lot of you guys did another really good thing that I liked was you wrote abnormals, you know, high, low on there. So that was good also. So lab work, his really are all just kind of like borderline, little up, little down. He didn't make anything that was like so through the roof that it went wah. But yeah, so his are just kind of like borderline, and it could be that those are chronically his numbers even without a gallbladder flare-up, just because of his poor diet and his health. So that's why I put them like that, so that they wasn't so alarming. There's that Murphy sign. See, that's what I was wondering, the ones who wrote Murphy sign on the first page, did you get to the second page and actually read it? Because I really thought everybody would get to the second page and read Murphy sign and go back and put on the first page. Anyway, Murphy sign. And that can be also done with that gallbladder ultrasound. And that actually, if you have somebody that has gallbladder disease and they come back from sono and you ask them how did that go, and they'll tell you that it hurt like no other because they were digging that sono head in there and it does not feel good. And then more testing, which like I said, we've already kind of talked about that. The HIDA scan, again, that's another one of those nuke med scans that they can do to look at the gallbladder function to make sure everything is working in there. So NPO, give pain meds, and then there's our sono reports that shows wall thickening or edema. And then some differential diagnosis, and these, granted, you're going to learn a little bit about everything, so these were just me doing my case study. Some other things that when somebody comes in with abdominal pain that they may find, you don't have to worry about writing these down or learning these. These are just, like I said, part of the, when you're thinking about the belly, there's a lot of organs in there, and radiation can happen all over, so one organ where you think the pain might be, you may find something else wrong once you get to looking. So left untreated, they can get very ill, they can get infectious, they can get, what's the big infection? Whole body? Sepsis. They can get sepsis if this is not treated. So they truly do want to take care of that. If you have an active, somebody comes in that you have a true active infectious gallbladder process going on and your liver enzymes and everything are truly high and elevated, the surgeons here will, one, admit you and try to let it calm down for 12 to 24 hours, or they will transfer you to a GI doctor in Salina to do the ERCP to go and retrieve that stone. Because they don't want to take you to surgery when you have this big infection process going on, because sometimes, you know, you go to cut into things and it can release and get in bloodstreams and stuff like that. So, so that is one thing that they will do here. And then, like I said, most people go home either on the same day or the next day. Another thing I wanted to give you guys kudos on is when you talked about what complications he's at risk for. the ones who put like respiratory or pneumonia. Anybody with post-op problems, that's one of their high priorities, is you want to get them breathing, you want them to cough and deep breathe and get them up and moving to clear all that anesthesia out of their lungs. So those who said that, good job on that. Like I said, you guys really did a good job on your case studies. I want no lifting, and I think on one of you had a post-op question on your test last week also about priorities as far as, and driving, we all know nobody should drive right after surgery, so that's not really as important as, you know, some of the others like, you know, coughing, deep breathing, your diet, talk about elimination, things like that. So call the surgeon for fever, nausea, vomiting, yellowing of your eyes. Has anybody seen jaundice on a patient yet? Yeah? So you'll see it in the eyes, one of the first place on the eyes that, you know, when you pull down and you look at the sclera, it can be yellowed. Then you'll start seeing it on the skin, and you can usually see it over bony prominences first, so like sternum, you know, if they're, you know, they're skinny, you can see them over places like that or on the cheekbones. But you'll see it in the eyes if you look at them. And you will, you know, it's sad to say, but I have seen people that are as orange as a pumpkin. They literally look like a pumpkin. They can get that color. So you can get a nice yellow jaundice up to looking like a pumpkin. So, okay, my references are at the end with my up-to-date stuff on there. Any questions on this? I looked at all of Alicia's notes on her stuff too, and I believe I got everything on there. Any questions? No? Okay. Thank you guys for letting me speak to you, and I will be here some more this semester, so.